So today, so today we're going to just go through kind of a little bit of an intro to global health. Those of you that don't know much about it will hopefully provide some background, but and just provide a refresher for those who know a lot about it. Then we're going to go to the history of GlobeMed. Then we're going to go to the current GlobeMed model, talk about our partner organization, which I'll explain about later, and then about how you get involved. So I thought I'd start out with a really short, succinct definition here. Global health is fashionable. It provokes a great deal of media, student, and faculty interest. Has driven the establishment or restructuring of several academic programs. Is supported by governments as a crucial component of foreign policy and has become a major philanthropic target. Global health is derived from public health and international health, which in turn evolved from hygiene and tropical medicine. Global health refers to any health issue that concerns many countries or is affected by transnational determinants such as climate change or urbanization, or solutions such as polio eradication. So I think there's a couple things that we can just highlight in this definition. One, that global health is fashionable. I wouldn't necessarily say it's fashionable, but it kind of, I don't know, it's an up-and-coming thing. It's really important in today's world, and there's a lot of interest in the field. Secondly, it's affected by transnational determinants and solutions. So this is a worldwide, these health problems are worldwide, and they also require worldwide solutions. But global health hasn't really been that big of a priority in the past. This diagram here on the left is a diagram made by a Roman philosopher, mathematician, astronomer, Ptolemy, who said that, you know, the world, the Earth is at the center of the universe. And he kind of reflected the sentiment of kind of Roman civilization in general. And a lot of advanced civilizations, you know, that the Earth is the center of the universe and that their civilization is kind of the center of the world. And that is kind of carried through to, you know, the 19th century, the 20th century, where a lot of developed nations such as the United States and elsewhere have really kind of ignored many of the problems faced by others. So Thomas Friedman and many others have declared the world to be flat. We're in a period of really extreme globalization where information technology, transportation technology is making the world much closer. And that's kind of what's led to our noticing that there's really vast inequalities in this world. This is just, as you can't tell, I'm a geography major. So I like maps, but I promise this will be the last one. So this is a map, a cartogram, percent of population living on less than $2 a day. So it's scaled by area. So India has a very high population living on less than $2 a day. Sub-Saharan Africa, China. And if you see it up here, North America just looks like a little tiny sapling of a tree. So we really live in a world of vast inequality, and this is just one example. When you put biological disease into the picture, with all these social inequalities, the intersection, the overlap, produces health inequity. An official definition of health inequity from the International Society for Equity and Health is the presence of systematic and potentially remediable differences in one or more aspects of health across populations or population groups. So this could be unequal access to healthcare services, this could be unequal health resource allocation, this could be unequal quality of services, this could be unequal delivery of effective services, and also, most importantly, unequal health outcomes. And Paul Farmer, in his book Infections and Inequalities, has a really good quote. He says, "The inequalities of outcome I describe are, by and large, biological reflections of social fault lines." He goes on to explain, using HIV as an example. He says, "Moving along social fault lines, HIV continues to entrench itself among the world's poor and marginalized, making enormous gains in parts of Asia, Africa, and Latin America." And I really like this quote, particularly because of his use of the term social fault lines. I think it kind of, I don't know, it gives me the message that, you know, these social fault lines, these inequalities really have the potential for a disaster, and that we should act. And these social fault lines, they occur across countries, and they also occur within countries. People in our global health class, we actually talked about that today. So between regions and countries, we have this life expectancy at birth. So up here are the more developed regions. So on average, people live to age 75. And then a third of that age, in the least developed countries, people live to 50, which really shows a great health inequity. Another example is a woman living in sub-Saharan Africa has a 1 in 16 chance of dying in pregnancy. This compares with a 1 in 3,700 risk for a woman from North America. It's really astounding, and there's much that can be done. And then also social fault lines within, take Uganda for example. These are statistics relating to the poorest quartile to the richest. So 192 out of 1,000 children under 5 die every year in the poorest quartile, whereas 106 out of 1,000 die in the richest, which is almost a 2-to-1 ratio. Women and mother malnutrition, it's 3 times worse in the poorest quartile, and delivery assistance, only 1/5 of the poorest quartile receive delivery assistance when they're giving birth, whereas over 3/4 do in the richest. So there are some possibilities for alleviating these problems. This is kind of just a rough list I put together, but you can really approach it from either the social inequality side or the disease side. On the social inequality side, you can work on development programs, you can improve education, and you can also improve race and gender relations. On the disease side, you can better primary care, you can really increase prevention, and a big part of prevention is health education. Any one of these will decrease the health inequity in the country. So that's where GlobeMed comes in the solutions part. GlobeMed started as a medical supplies mission in Northwestern University, started by a group of students in 1999. And then in 2001, it became the Global Medical Relief Program, an NGO, spread to a couple of different campuses. And its goal really was to donate medicines to war-torn regions. But then in 2006, the GlobeMed National Office underwent a huge shift, and they really changed to the philosophy that they are today. The current GlobeMed model, GlobeMed aims to strengthen the movement for global health equity by empowering students and communities to work together to improve the health of the impoverished around the world. How do they do that? They're really based around a partnership concept. So they take chapters at universities and they partner them with a community-based organization in the third world. And together they work, the chapter and the organization work on projects that will improve the health of the community in which the organization exists. If you take the 19 chapters that exist in the GlobeMed network, that's 19 communities served, and GlobeMed is growing every year. This partnership concept really utilizes the strengths of the chapter and organization and fills in some weaknesses of both. The chapter has a lot of resources, both social and financial. They have dedicated students, and they also are a new source of energy to give to the organization. The organization has a presence in the community. They have trained staff, and they also have health knowledge specifically about the health ailments in the community that they serve. So I'm not really going to go over this slide all too much, but there are some criteria that chapters take when they're choosing their partners. They have to have an effective model and infrastructure. They have to be community-based. They have to have quality project ideas, and they have to be impacted by GlobeMed.